Well, good afternoon again, and thanks so much for joining us today in the final webinar in this syphilis series hosted during STI Awareness Week by the New York City STD Prevention Training Center. Just as a reminder for a few housekeeping items, if you have any questions during the webinar, please type them in the Q&A box and not the chat box so that we can easily track questions. After the webinar, we will be sending out a copy of the slides as well as instructions on how to access your CME and CNE credits. The webinar will also be recorded and posted on the New York City Prevention Training Center website. I'd like to introduce our speaker this afternoon, Dr. Natalie New. Dr. New is the medical director for the New York City STD Prevention Training Center and a professor of pediatrics at Columbia University Medical Center in New York. Dr. New is trained in pediatric infectious diseases and has specialized in adolescent HIV and STI care for the past 25 years. Dr. New also participated in the writing of the 2021 CDC STI treatment guidelines as a workgroup member. Welcome, Dr. New, and thank you so much for your presentation today.
Thank you, and thank you everyone for joining us today. We're going to sort of wrap up this discussion this week with some cases around syphilis. Just to put it out there that some of the cases are real, some of them are from providers in our region. None of the names are real. Some of the data has changed to make it more interesting. If you have questions during this webinar, please put it in the chat. We'll try to answer them as we go, and then hopefully at the end we'll have some time for questions. So let's start off with a case. This is Ricky. He's a 25-year-old cisgender male who presented in August for PrEP. But at that time, when he had his screening done, he was found to be HIV positive, and he also had syphilis as well. In terms of his social and sexual history, his partner had HIV or has HIV, and he came here recently from Venezuela walking through the Darien Gap. So we are seeing a lot of new immigrants to the US with a similar history. At the time of presentation in August, to establish care, he was started on Biktarvy. His initial viral load was 62,000, and 1 month later, he had already gotten down to 29 copies. So he obviously had good adherence. Trying to figure out how to advance. Okay. So in terms of our approach to understanding his sexual history, we're going to remind everyone about the 5 Ps that you should try to use when you are discussing these sexual health issues with patients. So partners, he has 1 partner, male partner. Over the last 3 months, he's had about 4 over the last 6 months. He practices oral and anal sex, both top and bottom. Pregnancy is not applicable in this situation. In terms of protection from STIs, he uses condoms sometimes, never for oral sex, and about 50% for anal sex. And in the past, he's never been tested for STIs. In terms of his initial labs, his HIV test is positive, as we mentioned. His viral load is 130,000. It was, sorry, I put the 68,000 before. His RPR was 1 to 256, and he had the 3-site testing for gonorrhea and chlamydia because of his description of his sexual practices, but also because he identifies as an MSM. So we're going to do a couple polls during this talk just to get everyone engaged in discussing. What do you think his syphilis stage is at this point? Is he in the incubation phase? Does he have primary syphilis? Does he have secondary syphilis? Latent syphilis, late latent, or I don't have any idea, so I definitely want to talk about it. We'll give everyone a second to put in some of their thoughts about what he has. All right, we're at a lull now. We've gotten almost 100 people. So let's see what people should say. So some folks, 27%. Can you see this poll, Gary? Yeah, okay.
Yes,
Uh,
can you see it, Natalie?
Yeah, I can see it. I just want to
Mhm.
know if everyone can see it. So 27% think that he has primary syphilis, 12% secondary, and 24% no idea. So we're sort of even between primary and no idea. So let's talk about it. What does he have? So this is good. So let's review his history so that we can understand staging for syphilis. And hopefully some of you were able to attend the first talk that was given by Jacob, but he's new to your clinic. He's never had STI testing. He has no current symptoms. So the symptoms that we're looking for in order to stage him, we remember primary is the chancre. Secondary, you have the rash on the soles or the hands or other parts of the body. And tertiary, you might have these gummatous lesions either on the skin or elsewhere. So he doesn't have any of those symptoms. So clinically, we can't stage him, but his titer is 1 to 256. So what does that mean? He doesn't have any previous titer that you have, and so he has latent syphilis or syphilis of unknown duration because he's never been tested before. So this puts him then, if we look at our syphilis staging categories, and you've seen this before, and this is in our monograph, he's in the late stage. So we know that he was exposed, so we're out of the incubation phase. He doesn't have the symptoms of primary syphilis, which we discussed before, can either be a single or multiple chancres. He doesn't have skin rash findings of disseminated syphilis, and he is probably more than 1 year in terms of early latent. You can see on the bottom of this 12-month periods, but we don't know what he is. So he's in the late latent phase. So I hope that is makes sense to everybody. So what is the treatment for that? The treatment for that, if for late latent or unknown duration, is the penicillin injection, 2.4 million units IM, given once a week in weekly intervals. Alternatively, you can use doxycycline twice a day at 100 milligrams for 28 days. So what happened for him was that this happened in August. And if you remember, that was at the time when we had the bicillin shortage. So he was treated with the doxycycline. So did he respond to treatment? So let's look at his titers. In August, he had a titer of 1 to 256. He came back in September and he had a titer of 1 to 128. This is a little soon to do titer, so maybe he came in for some other reason. We said, let's redraw it, but that was done. And then in December, he was down to 1 to 32. I also have a titer here for him in February, but we'll talk about that in 1 second. So did he respond to treatment? How do we evaluate that? If you remember from the previous lecture, we want a 4-fold decrease in titer. So he started at 1 to 256, you can see at the bottom, and he went down to 1 to 32. So if we look at the figure on the top, 1 to 256, 1, 2, 3, he's down to 1 to 32. So that is a decrease in titer that is 4-fold at least. So yes, he did respond to treatment. But what happened in February when he came back? His titer blipped up to 1 to 64. What do we make of this? We're going to launch another poll and see what you guys think we should do. So in terms of his treatment and his titers, do we retest him in 3 months because it's only a little bit of blip? Do we give him another injection with bicillin? Do we retreat him with doxycycline at this time? What do people want to do? And I do have to say, like, sometimes it's not There isn't a black and white answer. It isn't cut and dry. There are multiple approaches in this situation where you could be right. And there are multiple ways of handling. Like, that's the beauty of medicine. So we have quite a number of people who have answered the poll already. So some people say, well, let's recheck him in 3 months and see what happens. So the majority of people want to do that. And that could be a good answer because it is quite soon, and maybe it's just a one-fold change, so it doesn't really reflect what's going on. Other people said, 30% of people said, well, let's give him a dose of bicillin, and that could be correct. And we could, you might think that you have to assess his adherence to the doxycycline in that case, or you could retreat him with doxycycline again, because maybe you think he was re-exposed, I guess, because the 14 days would be a re-exposure treatment. So there we see the beauty of their multiple ways of thinking about the case, and they aren't, each one could be correct. So let's review the case and sort of just discuss it a little bit further. His titers in the beginning were 1 to 256. He got 28 days of doxycycline and went down to 1 to 32. So that is a good enough response. And the time frame with 4 months, that's actually a good, it's around when most people do respond and have the decrease. But because he's HIV, sometimes the time frame, as we talked about before in the previous lectures, sometimes the response to treatment could be a bit longer. So it could be 12 months that we would have to wait to see a complete response to with a fourfold drop in titers. 2 months afterwards, with an increase to 1 to 64, is really just a one-fold change. So it might not be that significant. What we have to do if this does happen with our patients is sort of what you can infer from some of your answers is we have to assess whether he had any new contacts that might have exposed him to syphilis. We also have to assess his adherence to the original doxycycline. We all know that taking doxycycline twice a day for 28 days is not that easy. So, you would want to make sure that he was at least able to take, over 90% of the course. You would also want to see if your clinic has access to bicillin. If you do at this time, you could consider giving him a dose. And that is actually what we ended up doing. We gave him a dose of bicillin at this time, and then we asked him to return in 3 months to recheck his titers. I don't have any data yet on those titers. I can let you know what ended up happening. But I wanted to share this table, this study with you all to sort of talk about the doxy versus bicillin, because this has come up quite often. How good is the doxycycline? And in one of our previous lectures, people asked, was there a head-to-head study? And actually, this study was comparing doxycycline versus bicillin in patients. It was done between 93 and 2000 by Khalil Ghanem and Dr. Rampalo from Hopkins, so two of the experts in syphilis. They looked at early syphilis. So it really isn't exactly where our patient is. So it's somebody who has acquired syphilis within the past year. But let's look at what they did in this study. They had close to 1,600 patients, 87 received doxy, 37 were eligible, and they matched those to 200 controls. In the bicillin group, they had 4 failures for a rate of about 5.5%, which is sort of the standard that has been recorded for people who've had failure for treatment with penicillin for syphilis. In the doxycycline group, so this was 100 milligrams twice a day for 14 days, they did not have any failures. The mean time to successful seroresponse was about the same in both groups, so about 100 to 130 days. So that's around 3 months, sort of very similar to our patient. Obviously, there are limitations to this study. It's only looking at early syphilis. It was one site that one group of patients. We don't have information about their HIV status per se, but I think this was some good data looking at head-to-head about why doxycycline is recommended as an alternative. But still, we need to think about, is it, can we extrapolate to the late latent syphilis with this data as recommended with the guidelines? So let's look at another case of syphilis to sort of challenge ourselves. This is Randall, a 23-year-old HIV positive male. When we look at his, he's coming into established care. His past STI history is that he was diagnosed with HIV in 2019. His past STIs include syphilis. And recently, when he came in March, he also, at another clinic, was treated for gonorrhea at that time. In terms of partners, he's actively sexually active with males only, 2 partners in the last 3 months. He practices oral and anal sex, both top and bottom. He uses condoms with one partner, but not with the other. And his pregnancy intention is not applicable. In terms of his assessment in the clinic when he comes in to see you, you want to know, well, what stage was he for syphilis when he had? Because you're going to be getting labs at this time. So you want to get titers, and you want to know, how did they stage him in the past? You're going to do 3-site testing. He describes his sexual practices. So you want to swab all 3 sites. And you want to swab him for reinfection because he was recently treated for gonorrhea. I mean, it's 1 month later, so it's a little early, but still, it's a safe time where you can reswab to make sure that the treatment was accurate. If it was pharyngeal gonorrhea, this is the perfect timing. So 3 weeks to 4 weeks after treatment for pharyngeal gonorrhea. In terms of his HIV care, you're going to do viral loaded T cells, standard intakes. You're going to assess him for immunizations, what he needs in terms of meningitis vaccine or pneumovax, and you're going to offer him and discuss doxy-PEP. Some of these concepts might be new to everybody, and if they are, let us know in the chat, and we can add that talks on that to everybody in the future. So Randall's stage of syphilis. So let's sort of review, what did he tell you when he came? Oftentimes it requires looking at the medical records, going back and looking in Care Everywhere and trying to understand what he did, how they might have staged him. So in terms of his history for syphilis, he first was diagnosed in 2022. And then again in 23. In 22, he got some shots, but he doesn't remember how many, and you don't have any access to that. In August of 23, he got a single dose of bicillin. And here are the titers that we found in his chart in Care Everywhere. In 22, the titers were 1 to 128. In 23, they were 1 to 128. So about a year, slightly less than a year later. In January of 24, he was 1 to 32. And in March, he was 1 to 8. Just reviewing again also for syphilis in terms of what happens and the stages, we have to think about both the titers, but also clinically. He had no clinical symptoms at the time when he came to clinic. So it's not primary syphilis, it's not secondary with the rash, more like probably latent, but we have to think about it in terms of the titers. So in August, when he presented, and we're going to launch another poll, what do you consider his stage to be for syphilis? Does he have primary? Now remember, primary is a clinical presentation. Secondary, again, that's a clinical presentation. Does he have latent? You have to remember the timing of the titers that we have, or does he have latent? Gonna give everyone a second to fill it in. You guys are amazing. Excellent. So we have quite a number of people here who have shared. So the majority say that he has latent syphilis. Excellent. And we could argue with the latent, but let's look at the data to sort of figure out why it is probably not that. And then remember, for primary, you need to have an active lesion, an ulcer, and secondary, a rash, which he did not present with any of that. So it's probably neither of those. So in terms of his history, did they treat him correctly? Why or why not? Let's look and see. So in August in 22, he had a titer of 1 to 128. He came back a year later to the outside clinic and he was 1 to 128. If you look at the timing, he's so close. And so he's under a year. So you have lab tests within a year with the same very high titer. But remember, sometimes it could take over a year for the titer to go down. And so giving him a single dose is actually adequate to treat his infection. Here you can see on the right in terms of the treatment response. And so did he make a treatment response going from 1 to 128 to where we are in March of 24 to 1 to 8? That is a more than a 4-fold drop in titer. And so therefore he was adequately treated. So in terms of the staging for this young man, he's early latent because of the timing of the titers, and we treat him with a single dose of IM penicillin, 2.4 million units. Again, you can use the doxycycline, 100 milligrams twice a day for 14 days, and then assess his response. Oftentimes in our patients, in our HIV infected patients, I would say, we have them come in every 3 months for STI evaluation and assessing for titers. And if you're concerned about whether, adherence to medication or response to therapy, having them come in every 3 months is reasonable in terms of rechecking the titers and assessing for whether they're newly exposed or not. Let's move on to another case. This is a 53-year-old HIV negative man. In May of 21, he had a titer of 1 to 256. At that time, he was treated with 3 doses of penicillin, and he was diagnosed with latent syphilis. In February, so a little shy of a year later, he came in and the titer was still 1 to 256. He was given 28 days of doxycycline at that time. And he was also diagnosed with latent or possibly failure. So what does this mean? What are your concerns about this case? And what do you have to think about? The team was not able to get titers initially. So that's one thing that we often find is if some people are going in between care sites, you might not have follow-up titers. And this is a problem in terms of assessing whether somebody responds to treatment. The titer is the same 1 year later. Well, why is that? There's a couple of reasons that you could think about. Does he have reinfection? You don't know what happened during that year's period of time. Could he have failure? Well, that is definitely of concern, especially with a titer of 1 to 256. Was he not adequately treated? He did get the doses of penicillin initially, but we don't really know whether they were correctly timed. So 1 week apart, there's a little bit more leeway in somebody who is not pregnant in terms of, you can give it 9 days, 10 days, and still it will be considered adequate treatment. But we don't know exactly when he was treated or what the interval was to assess whether it was treated adequately to assess for either a failure or reinfection. So what do you have to do next? Well, the most conservative thing would be to assess for occult sites. So what does that mean? And the CDC guidelines I'm going to show you in the next slide talk about assessing for, if this is a failure, could there be occult sites for infection, like the eyes or the ears, and how do you assess for that? Should you do a lumbar puncture at this time? You should obviously assess for signs or symptoms of neurologic syphilis, and you could make a case for doing a lumbar puncture at this time because the titer remains high after adequate treatment. So what does it mean to assess for ocular or otic manifestations? So for ocular findings, you want to consider symptoms such as panuveitis. So does somebody have problems with their vision? They can have any structure of the eye can be involved. So they can have conjunctivitis. They can have pain in their eyes. They can have a red eye. They can have findings of visual loss. You can ask somebody, have you had to have a change in your prescription for your eyeglasses? These are all important findings to ask about in order to assess whether this could be ocular syphilis. And just remember, if it's not treated accurately or correctly, it could lead to permanent vision loss. What about otic syphilis? So you need to assess for tinnitus. So does somebody have, ringing in their ears? Does somebody have vertigo? It can either be one side or both sides. It can often occur all of a sudden, or it can be progressive. And also to remember, hearing loss, if not treated due to otic syphilis, can result in permanent hearing loss. So these questions and this assessing this when somebody comes in and has syphilis should be part of your regular standard evaluation. So just to go back 1 second, in him, doing any of this, doing an LP and retreating is accurate. Assessing for syphilis, if you're going to say that he has neurosyphilis, or that if the LP is abnormal, and I didn't put the treatment there, but that's going to mean that you're going to have to admit him or get an IV placed and treat him for neurologic, otic, or ocular syphilis, which is IV therapy for 10 days. So let's move to the other spectrum, to children. So I hope there's some pediatricians on today or some family medicine docs. This case is a 1-month-old who presents to the emergency department with a rash. The patient fell off the bed, and so the mother brought the baby in. At that time, they did an exam. They did a chest x-ray and a CT of the head. And so it's sort of like getting a babygram at the time because the baby fell. And the radiologist calls and says, oh, there's something unusual on the film. The mother of note in the history, too, is a 29-year-old female. She says, well, I have a similar rash to my baby. It came a couple days ago. When you ask her about her medical history, she says, oh, my labs are all normal. My RPR was non-reactive. And you could see in the chart that it was. But just before delivery, she had vaginal sex with a new partner who had just been released from jail. So when they did the films on this baby, and this is just representative, and this actually did happen, you can see this metaphyseal abnormality, and also in the epiphysis, how there's this lucencies there. So the mother's rash may look like this, and the baby could have peeling of the hands. So when you do titers on the baby's titer is 1 to 1024. Similarly, mom goes to the emergency department and her titer is 1 to 124. So when you're considering congenital syphilis, so this baby is presenting late, and this probably was because the mother was infected at the time or around the time of delivery. When you're entertaining the diagnosis of syphilis and somebody comes in, and if somebody is symptomatic, you're going to want to start the penicillin while awaiting your test results. If they're asymptomatic, obviously you can wait, but you would want to start that in this baby. In terms of congenital syphilis, how do we stage these congenital syphilis? Well, if you remember from the lecture from yesterday, we have the 4 categories: confirmed, which is highly probable. In those cases, the baby's exam is consistent with syphilis. Baby's RPR is elevated, the same, if the mother has a titer or is elevated, or you see spirochetes on an exam, dark field, that is. If it's possible, you want to assess the treatment for the mom and whether that was accurate. Less likely, so if mom was adequately treated during pregnancy, or unlikely, mom was treated before the pregnancy. So what stage is this baby? And we're going to do a poll again, see what you guys think. And remember, this baby's coming back. Oh, pretty much no-brainer there, everyone's saying. That was very quick. All right, I can't fool you guys. So, correct. And let's see why this is confirmed syphilis. So the baby's exam is consistent with congenital syphilis, and the baby's RPR is elevated. In this situation, I think I have, yeah. So we'll review that in 1 second. So when you admit the baby's exam is abnormal. The baby has that rash that I showed you. The baby's titer is elevated. So in that situation, you're going to want to assess everything in the baby in terms of laboratories. You're going to do an LP, look at the protein and the glucose, and a VDRL. The long bone films that were done were abnormal in this child with the classic findings. And actually, this is how this baby was diagnosed, is because the radiologist had seen syphilis before and said, hey, I think this is congenital syphilis. You're going to admit the baby, give the baby IV penicillin every 12 hours for the first 7 days, and then every 8 hours to complete a 10-day course. So what are the symptoms of congenital syphilis? So, is this unusual? Well, no. We talked about this before on yesterday. Sometimes if moms are infected, as she probably was very close to delivery, the RPR is a very insensitive test and would not, even if you did it at the delivery, you might not pick up that the mother was infected with syphilis. Babies are born at that time alive, and you can see in this light green, they have dark green, no signs of syphilis at the time when they're born, and they still can have congenital syphilis. This baby, and I just highlighted in red, has long bone changes that are consistent with syphilis and a syphilitic rash. So when you're doing the LP, the baby may have a positive VDRL, elevated white cell count or protein, and could also have hepatosplenomegaly. This baby was treated and then followed over a 6-month period of time to make sure that the baby's titers came down. Here's another case that we should talk about. And this is a case I saw in my clinic, but after the fact. The mom is a 21-year-old mom. She's diagnosed with syphilis in her prenatal visit, which was in May 2023. She came in for delivery of twins in February of the next year, 24. The babies were born, their ACGARs were great, 8 and 9. And when you get further history from the mom, she tells you, well, I got 3 shots during pregnancy in another county. The titers, she said, got better I think that they got to non-reactive, but I'm not sure. Or they were negative, she might say. But then she came in preterm labor in November and got a single shot as well. At the time of delivery, the mother's RPR was 1 to 8. So what do you do in labor and delivery? And then what do you do for the baby? So when the babies are born, you're going to examine them and you're going to do laboratory evaluations. The baby's exams were normal. The baby's RPR is 1 to 1. And the babies ended up getting an LP, which was bloody in one, and then and the VDRL was unable to be done in the other. So you're sort of stuck in a difficult situation. So what stage is this baby? And I forgot to put the poll in here for everyone. I guess you can put it in the chat. Is this baby confirmed syphilis? Is it possible syphilis? Less likely? Unlikely? Oops. And so let's go over what happened with this baby. They did get treated with 10 days. So why? So let's look at the mom's titers. And this actually required a lot of work to be able to sort out what happened with the mom. And, unfortunately, sometimes when they call the pediatricians, you don't have all the data, and it does require that it just does require work to try to figure it out. So starting treatment and getting the data is fine to do. And it's the most conservative thing, especially when syphilis is on the rise. So when we look at the mom's titers, what I was able to find was that in May, she was 1 to 128. She responded and got down to 1 to 2. So when she's delivering in January or February, back to 1 to 8, and even she had a 1 to 16, that is an elevation, a 4-fold elevation from non-reactive. So the mom at the time in December, when you're trying to figure out what's going on, had no symptoms. Her first test in pregnancy was elevated. She got the 3 shots. We were actually able to find out from the Department of Health the date of those injections, and that took a while to figure out. You can see that the timing was 7 days between each one, so she was quite good about coming in correctly. So she was treated correctly during pregnancy, and we allow up to 7 days during pregnancy to say that it meets the criteria. But the problem was this titer that happened, 1 to 8 or 1 to 16, at the very end of her pregnancy, so within the last trimester or within the last month of delivery. This is the problem. So in her case, you might consider that this means that she may have been re-exposed to syphilis at the end of her pregnancy. So you might consider her inadequately treated or during pregnancy because of this, and possibly the infant would have syphilis. Therefore, because of exposure to a partner late in infection. So therefore, you might want to work up the baby and treat the baby for syphilis. Just to show you again, what does that mean? You examine the baby, you're looking for all these findings, hepatosplenomegaly, any kind of rash. You're looking for the long bone films to see if there's any abnormalities there, the lumbar puncture to see if the baby had any abnormalities. Unfortunately, in these twins, the CSF was uninterpretable. So it's sort of, even the titers show that the baby was down to was 1 to 1 on mother and was lower than the mother's titer. Because the CSF titers were uninterpretable, it sort of pushes you down the path of giving the baby 10 days of penicillin, which is what they did. Would you be wrong in saying that, oh, I'm just going to give the baby a single dose? Well, probably not. But if you look at this figure, and I know it's kind of hard to see here, you're probably all going to have to move in and squint. If the baby, if you review the titers for the baby and you do the findings with any abnormality, which is where she falls, this would mean that you would give the penicillin IV. Could you consider that the CSF and the baby's labs were abnormal, and therefore you're just going to single dose? You might, but because we could not do the VDRL, and in one case it was uninterpretable because it was a bloody tap, giving a single dose would probably not be an option in this baby. So here, just to review the guidelines for possible congenital syphilis, if it was under 30 days prior to delivery, then you're going to treat with the IV penicillin. They also give you the option of doing IM as a single dose if you can be assured for close follow-up. So how do we follow these babies? And this is another thing that we have to remember for these infants. In neonates who have a positive RPR, so this baby did 1-to-1, we're going to repeat that at 3 months, and then we're going to follow that baby until they're non-reactive up to 6 months. If the patient is treated at birth, it can take up to 12 months to become non-reactive. So you have to consider this if they're not treated, for 6 months, but up to 12 months, give that time period for the RPR to become non-reactive. If the baby's test is non-reactive at birth and the mother is positive at birth, then you're going to want to repeat the test at 3 months. So here I show you again, the mother's titers were elevated. The baby got worked up. The baby was treated. And at 3 months, we did the RPR and the baby was non-reactive. So all turned out well for this infant, or these infants. So I just want to remind everybody that syphilis is on the rise, and especially congenital syphilis. Syphilis disproportionately affects populations that have limited access to healthcare. So often young folks who are not regularly going to see their physician or their healthcare provider. Congenital syphilis cases, as we mentioned the other day, have increased to over 700% over the last decade. So it's really become a crisis. New populations to consider are infants who are adopted internationally or even within the US. And in terms of assessing the risk for congenital syphilis and early syphilis, about 50 to 75% are infected with early syphilis. If 15% of moms have had syphilis over a year prior to delivery. And syphilis can happen, congenital syphilis can happen at any stage during the pregnancy. So it's just so important to have that testing done during pregnancy. So I want to review that for 1 second again, because again, in STIs, prevention is key. So at the first prenatal visit, we should be doing testing at 28 weeks and then at delivery, if at high risk. So what does that mean? They do have some recommendations. Somebody who has multiple partners in a high prevalence area, and for us in New York, obviously that's high. We have a high prevalence area. Folks who are engaging with drug use, transactional sex, folks who have been with new partners, especially those who have been incarcerated, and they actually do have unstable housing in this criteria for who might be at increased risk. In terms of assessing the treatment response in pregnant women, you want to retest them 8 weeks after the treatment, which is different than in non-pregnant folks, really over the course of 6 months for those who are not HIV infected. And as we mentioned yesterday, sometimes you might not see a decrease because pregnancy is 9 months. So it makes it a little difficult for us to see that decrease in the titer. In terms of assessing whether a woman has syphilis or not during pregnancy, we are finding that some folks are having an RPR that's elevated at the end of pregnancy, you really want to see a fourfold increase to see whether somebody actually has a treatment failure or a reinfection. And so this makes it a little tricky at the end, and talking about these cases is key, but also evaluating them and conservatively and evaluating the infant is also critical. In terms of the management for the syphilis, we talked about highly probable cases are confirmed. It's IV for 10 days. In possible syphilis, you can, it's important that you do physical examination, evaluation for the infants, and then either the IV or the single dose of IM penicillin. In terms of if it's less likely, you really don't need to do this evaluation. So that happens when the infant has a fold change below, a fourfold change from the maternal titer, or if the mother was treated more than 30 days before delivery. In those cases, you can just give a single dose of penicillin on the way out the door and make sure you follow the infant. And if it's less likely, completely or unlikely, then you don't need to do an assessment for the mom. So this is a mom who's been treated during pregnancy or before. You really don't need to do anything for that infant. So I bring this slide up to tell you that we are the New York City STD Prevention Training Center. We have a consultation line here where if you have a case that you don't know what's going on or you want to evaluate, where we can help you, please send us a message. We also have a monograph that's online. I don't think we're going to probably update that, but we'll have to see. With great pictures, a lot of tables that you can access that help you sort of understand syphilis, both congenital syphilis and also syphilis in older populations. That really can be quite helpful.
Thank you so much, Dr. New. It was a fantastic presentation and really enjoyed hearing more. We had many questions that came in through the Q&A during the presentation, and our Assistant Medical Director, Dr. Jason Zucker, did answer a lot of them. But we do have a few more questions, and just a reminder, if you have a question, please type it in the Q&A box. So we have one question here that says, could you discuss transmission for secondary syphilis in more detail? The talk on Tuesday briefly mentioned that syphilis could be transmitted by sperm, blood, or breaks in the skin. My understanding was that in secondary syphilis, it is the mucus patches, sores, or condyloma lata that would be infectious. Is the body rash during secondary syphilis infectious to others? If so, are people in direct contact at risk, not just sexual contacts?
So, this is tricky. Those rashes are infectious. Probably not at the level by which the mucus patches and the sores are. Can I say 100% that you cannot spread it by close contact? I cannot. Have people done dark field of those skin lesions and found spirochetes? Yes. So if you can find them, then it is infectious, but not as much.
Great, thank you. There was just a comment saying I have seen bullous and ulcerated rashes before that could ooze spirochetes. Those are more macular, probably less likely to spread, but possible.
Yes.
So there's another question asking, can we discuss contacts of syphilis cases and their care?
Sure. So I think that in terms of contacts, syphilis and the Department of Health go one in one. So anybody who has a diagnosis of syphilis, both the lab and the provider should report that to the Department of Health. The Department of Health then goes out and will do contact tracing for those cases. When you have a case and a person who has syphilis, you should tell them that their partners need to be treated and evaluated. So oftentimes when we say, and sometimes it's over treatment, but because you're not 100% transmission, but we do give the partners within 90 days a dose of bicillin or doxycycline. 100 milligrams twice a day for 14 days, or and they need to do blood tests to see whether they're infected. Those tests might not be positive, obviously, right away, but may develop over time. So those partners then also need to have their serology followed over time. I hope that answers your question.
Thank you so much. There's another question about ocular syphilis. Can an ophthalmologist rule out ocular syphilis with an exam, or do you need to err on the side of caution and treat as ocular syphilis regardless?
Yes, so the ophthalmologists are fantastic about being able to diagnose ocular syphilis. There are some very specific findings that they see in terms of the retinitis, for example. And if somebody has visual changes then that are consistent and the titers are positive, then that is how we make the diagnosis, and they get IV therapy.
Thank you. The next question is, if a case is deemed as having had inadequate treatment, would you give any consideration to antibiotic resistance?
So, like, inadequate treatment could in bacteriology could cause resistance. I don't think that we have seen resistance to syphilis, but it is not something that we grow in the lab to be able to determine that. So if somebody's inadequately treated, not everyone responds to therapy, so I would retreat. And if you feel like somebody's been inadequately treated, then I would reassess their stage and decide what the appropriate treatment is. I don't know if, Jason, you have anything else to add for that?
No, I think that's exactly right. We had never really seen resistance in syphilis. Fingers crossed it stays that way, but
Yes.
Thank you. There is a question about condyloma lata, and if you could just talk a little bit about what that is.
So those are like wart-like lesions that can appear in the perirectal and anal region. They're sort of bulbous looking. We have the CDC has photos that you can Google and look online. Also in our monograph, we have examples of what that looks like. Sometimes it is difficult to distinguish from HPV, but but it's more bulbously looking lesions.
Thank you. We don't have any questions right now, but if anyone has a question, please put that in the Q&A box. And just a reminder to everyone that we will be sending out a copy of today's slides, as well as your instructions on how to access CME and CNE. And we will also be posting this up on our website shortly in the next week or so. And so you can view the archived version.
I think for also in terms of references, somebody asked about for the talk, really my go-to is the CDC STI treatment guidelines. They have over 600 references there if you want to look up the specifics for what they recommend. But also in terms of, it's a great resource for looking at syphilis and syphilis staging and treatment. There is also an app for your phone, which I use on the daily, where it will also link you to the treatment guidelines and how to diagnose things. So I would recommend everybody getting that as well on your phone.
Great. Well, thanks so much, Dr. New, and thanks, Dr. Zucker, for answering a lot of the questions during the webinar. We don't have any additional questions, and we just want to thank everyone for joining us today. And if you joined us for the previous 2 webinars, we're really happy to see you again today. But thanks so much, and hope to see you at a future webinar.
Thank you, everyone. It's been a pleasure. And just to remind everyone, syphilis is difficult. Don't worry if you don't get it. Dr. Zucker and I talk all the time because we always, am I doing the right thing? So just reach out. We're here to help you. Talk to your colleagues. It is what it is, and keep testing.
Thanks so much, Dr. New.
Thank you, everyone.